Hi, I'm Pete Nelson from the University of Kentucky. I'm a neuropathologist. I was invited by Dr. Schneider to speak on behalf of the Neuropath Core Steering Committee. And then Dr. Schneider and I together invited Dr. Keene, who will discuss the experiences at the University of Washington, which was an early area affected. And Dr. Keene actually has some special insights and contributions of his own. And then I hope that we can leave about 5 or 10 minutes at the end of our time slot for questions. Next slide, please. So in this short discussion, I'm just going to give an overall scope of some of the problems and issues, describe some of the discussions we had on the Neuropath Core listserv, discuss some of the specific issues. The goals here are just to bring up some things that everybody's going to probably have to deal with, and in the hopes that maybe we can collaborate and work together to solve the problems. And one of the things that we might do is end up producing some one or several group-derived guidelines for helping the ADRCs to get back up and going with brain autopsies. And then I'm going to finish with some notes of caution, as then I'll pass it over to Dr. Keene. Next slide, please. So in terms of the scope of the problem, when I say problem, it's all about safety and unknowns of a dangerous new pathogen that is highly communicable, very aerosolizable, and sometimes all too often lethal. There's just too much that's unknown about it. I can just give a bird's eye view and a bug's eye view first, though, is that our University of Kentucky autopsy suite is currently closed out of safety precautions. And I know that from talking to my colleagues that most of the Veteran Affairs autopsy facilities are closed. In the medical examiner, the ME circuit, most of those autopsies are either closed or very seriously curtailed. What about then in the ADRC system? Next slide, please. A couple weeks ago, we had a discussion on this topic, and it was good. There was a very good, I thought, feedback and discussion from around 20 different ADRC neuropathology core leaders participated. I was thinking of doing some sort of survey or poll of people to see what their practices are, but I think that those are changing so often that people may be tempted to say, am I going to talk about what I did today or next week or tomorrow? Because things can be changing, and so we didn't do that. But clearly, most of the people who piped up seem not to be doing autopsies at this time, at that time, which was a couple weeks ago. I know that several ADRCs are now up and going or will be starting soon, and some are doing autopsies via proxy services, maybe offsite autopsy technicians or offsite pathologists. Another thing that was raised on the listserv was concern about taking personal protective equipment from our clinical colleagues, which in some places is a dire problem. Next slide, please. Just speaking, so the Neuropathology Core Steering Committee is currently made up of me and Andrew Lieberman and Ann McKee. Among us, we have some concerns. The things that we voiced together include that the safety assumptions that you can make about this are very unpredictable. That what you can say about prions and other viruses are not necessarily true about this novel pathogen. What about its aerosolizability, which is currently not completely known? You see stuff in both the popular and scientific press that's all over the place. And so there are just important questions to ask. An N95 mask means that 95% of small airborne particles are removed. Is that enough? And so let's say that you add a vacuum on your bone saw and you use a negative pressure system. Are that enough? Is just a little bit too much, or is it not too much? And let's say that you have an autopsy and you do it for 10 times with a vulnerable autopsy technician and it works, or 50 times, but a disaster could still occur. And so the important point is that we want to be doing autopsies. We want to be getting going. We know that autopsies are not the only branch of clinical research and research in general that have been put on pause, but we want to get things going. And so how are we going to do that? Next slide. One of the things that we need to acknowledge probably going forward in order to, in the short run, get things going, as I'm saying, is to have there be a much more expansive testing related to the neuropathology cores. And I say testing, not questionnaires. Questionnaires have been shown to be not at all fail-safe. People that check none of the boxes are sometimes positive. We have good anecdotal evidence of this, which Dirk may talk about. We're talking about safety of the autopsy personnel, but we're not just talking about in the morgue. What about people that are doing downstream experiments on the frozen samples? And also, what about the brain changes that are actually due to the COVID-19 itself? It's a very inflammatory mediator that may affect the brain, as people have probably seen. And then something that hasn't been talked all that much about is the blood draws and the CSF draws in the ADRC clinics. What about live people testing? Because we process these samples, and there are probably issues related to the processing, banking of blood and CSF. I can say that at the University of Kentucky, we had a clinical pathology person who was tasked with processing blood samples become COVID positive, and it's unclear whether her infection was due to her tasks in the ClinPath lab, but it may have been, and so there are issues of concern. And then let's say that you were tested. Is it one test means that you're tested? Is it two tests? What is it? Sensitivity and specificity of the various tests and the serological versus PCR testing. In addition to issues related to testing, we also are wondering if there should be new autopsy methods in PPE, for example, vacuums on the saws that need to be required or recommended. And it probably should be acknowledged that for the next few months, there's going to be probably a shortage of short PMI frozen samples. There's also just a lot of uncertainty. And when there's uncertainty, then this also manifests in the study sections and reviews. And people sometimes want to have there be guidelines to help say that you're doing the standard so that reviewers don't ding you. We've heard some pushback already in study sections related to biosamples. So that is something that we can also help with. In this uncertainty, then it'd be probably good to have some guidelines for helping everybody. Next slide. There have been some guidelines published both by the CDC and by the Royal College of Pathologists in England. There's been some concerns about their specificity. They're very incomplete. They're listed here, though, for anybody who wants to come and get this PowerPoint. Next slide. But there is a need for more specific COVID-related standards or procedures about how you do tests, how you report the tests after death for the autopsy samples and before death or during life for the bloods and the CSF. We need some guidelines to help to describe what the suspected infectivity is of something that's been fixed or embedded, or just the blood, CSF, or fresh tissue. Can we recommend safety precautions? How about fields and data entry fields that would be appropriate for NAC or other centralized repositories? And again, this is not one size fits all, but we are wondering about how we can make recommendations. Next slide. In terms of where these guidelines would occur or where they would emerge, Dr. Keene is producing a document that I think everybody should read about the way that we can get going, some of the boxes that need to be checked, some of the considerations that need to be thought about, and I'll let him talk about that, or we may talk about that during the answer session. The Neuropath Core Leader Steering Committee is glad to help. There's also a best practice document that Dr. Silverberg, Dr. Glazier up at IU and others are working on. And so it's unclear exactly where these will emerge. And there's also a grant that came out about COVID with a specific section on neuropathology, which may be a good venue for studying the specific safety precautions necessary to perform autopsy or other biosample evaluations. Next slide. So I'm going to conclude then before passing over to Dr. Keene by saying some notes of caution. A medical examiner in Thailand apparently contracted the virus during an autopsy. It shows that it can happen. This pathogen is new, it's aerosolizable, it's very contagious, it is way too often lethal, and there are tons of unknowns. Murphy's Law applies. Primarily, we don't want any autopsy or research worker to get infected. And that's the most important thing. But if somebody gets sick or died during or due to an autopsy or biosample evaluation, it would be a great tragedy in itself, primarily. But beyond that, it would broadly and meaningfully set back precedent and future research efforts. I think that we really should be careful and not overreach and not use ourselves necessarily as guinea pigs. And I think that we need to be careful, at least for the near future. And I say that partly because that's what I think, but I've heard a number of other people say the same concern. So with those considerations and concerns, which I wanted to describe, I will pass it over to Dr. Keen for his excellent insights and experiences.
Thanks, Pete. I appreciate that. I'm going to try to share my screen just because the animations might work a little bit better. Hopefully that will work and I'm not risking disaster. Can people see my screen right now?
I can.
Yes, we can.
Great. So I can use my mouse too. So I have a few slides just describing the UDub experience. I just want to open by saying we went into this with several thought processes. I want to first and foremost echo what Pete said. Safety is absolutely the #1 concern. And I think you'll see that we've approached this at every step of the way with safety in mind. I also went into this, and it was every day was a new thing for a while. But recognizing the importance of these brain donors and the investment and the knowledge that would be lost if we were unable to accept these donations, in addition to the critically important knowledge that we almost completely lack right now about the effect of SARS-CoV-2 on the central nervous system. And so I think there's tremendous value if we can safely take these brain donations from our cohorts, of course, who are well characterized, whether or not they have an active or have cleared a COVID-19 infection, because it's going to have a long-term impact on the neuropath. It's going to have a long-term impact on I think a lot of what we do. And finally, I went into this with the mindset that it's unlikely that this is going to be gone. That we're going to somehow be miraculously free of coronavirus and SARS-CoV-2 in the next few months. This is something that we're going to have to deal with long-term. And so we were very active in trying to figure out ways to make this happen. And so I'm just going to start with a timeline and diverge a couple times along the way. So between January and February, and you can see this isn't to scale except for how long these months actually felt. In the first couple months of the year, we had 26 cases. We were plugging along okay we had 13 cohort rapids, which is a little bit low. And our PMIs were pretty good for our rapids. We cut our rapids off at 12 hours. So anything after 12 hours is a non-rapid. These are the sort of timelines that people are familiar with. These are probably going to be revised for sure, but the first case was identified in Washington in January 21st, and then the first death was reported in February 29th. There were clearly deaths before that, as the Santa Clara data is showing, and some of these 26 cases may actually be COVID-19 deaths. We will go back and see if we can find that out. And so basically after the first death, and I don't know if I think this was timely. Up until this point, there wasn't a lot of evidence of community spread that was really concerning. But on March 3rd, we started screening with a questionnaire, as Pete said. This is where our questionnaire has developed. It didn't start this way, but these are the critical components of the questions that we ask. And we still do this because if someone has a COVID diagnosis, we should know. If they're suspected to have a diagnosis, if they've been exposed or in a facility where there's an active infection, I think that's important to know. And then the symptoms continue to evolve. I put these up yesterday based on the current list from the CDC. That continues to change. And we ask the caregiver that's responsible for our donors, whether it's a loved one, whether it's a nurse, about these questions every time we have a donor come through. So we started the screening questionnaire, and you can see our PMI didn't change very much, but our rapids went down quite a bit because this is when social distancing happened. And so we used teams of 2 technicians, and we really didn't feel comfortable having 2 people in close proximity once the work at home restrictions were applied. So we were continuing to take rapids. All of our cases screened negative. including this donor on March 22nd, who unfortunately screened negative with our questions, but then we were informed later that day after we had done the removal by the medical examiner that there was actually a case in the facility that we were not told about, even though we asked. And anecdotally, on March 26th, that donor tested positive. The test came back. The technician who did the procedure was tested 4 or 5 days later and has been negative and has not and has continued to be negative and asymptomatic. But that instituted a real change to the point where we had to test all our subjects for COVID-19 before we could do the autopsy. We would not perform an autopsy until we had the testing in hand. So the decedents would come in, we would test them, and then we would wait. So of course we had 0 autopsies, and you can see what happened to our postmortem interval. This is biased by one really long outlier, but our average without that outlier was about 3 days. We can get better. We needed a rapid test for that to really accentuate that, and so at that point we made we were putting our resources and our efforts toward 2 lines of interventions. One was access to a rapid COVID-19 test. The other was to engineering and safety protocols that would allow us to do this without knowing COVID status. This is a little snippet of the draft document that I've put together that Pete has seen and the Neurobiobank folks have commented on, and the Neuropath Steering Committee. I don't need to go through all this with people, but we've put a lot of thought into how are we going to continue to function and come out of this and still be able to honor the wishes of our donors and support science with brain donation. Rapid SARS-CoV-2 testing, preferably point of care that takes minutes, will be awesome. We don't have that yet. The University of Washington has developed a rapid test that takes about 2 hours, and so we were working toward implementing that, and that went all the way up the chain through our infection control. The test is prioritized for patients. There are open spots that are unused, and so our lab medicine folks have allowed us to use those spots if they're not needed for a patient. Those tests are run every couple hours. And then there's a whole lot of engineering controls and other criteria that are needed to basically be able to do a safe autopsy on a COVID-19 case. And then there's specific considerations that every neuropath core is going to have to deal with, because every one of us has different protocols. For us, with respect to engineering controls, we actually embed our fresh brains and our rapids in dental cement and cut them that way. That actually ended up being good. That actually it provided some comfort to the EH&S folks as far as cutting fresh brains, and then we slice our fixed brains on a brain slicer that in agarose embedded brains, and so those are considerations, all of which had to be evaluated by our environmental health and safety people. So we went through an enormous amount of protocol development and reviews and site visits to get everything set from that perspective. So on April 21st, we deployed our first rapid COVID test on a donor. It just so happened to be positive. So, and we were not set up to accept COVID-19 brain donations yet. We did get final approval to be operational for COVID positive cases on April 23rd. That is dependent upon several really important things. Number one is use of the King County Medical Examiner isolation suite, and I'll talk a little bit more about that. On 4/27, we had our first rapid autopsy that did not have a prior COVID-19 test. So we basically thought we had deployed all of the safety protocols and were approved by our environmental health and safety people to perform these cases regardless of whether or not we knew they had COVID-19. Everybody gets tested, of course. And actually, we're doing a case right now, so this should be 4, with an average PMI of 21.9 hours, and that'll be 2 rapids, probably with an average PMI of 5 or 6 hours now that we're basically back up and running. So what are the key elements? I want to really emphasize, and I think Pete did a great job doing this too, but the really important considerations are, first, always prioritize patient care and always prioritize safety. And that's what we try to do. We reuse our PPE We have equipment that's outdated that was in our possession, but that still is functional, that the clinical people say that they don't need. And of course, as I said, the rapid COVID-19 test is only used if a patient doesn't need it. We do a lot to conserve PPE, and then the safety protocols that we've instituted. We have a buddy system, actually, which seems counterintuitive to have two people, but two people do a really good job of monitoring each other's PPE and helping support each other. It also allows us to have one person with our ULPA vacuum. This is ultra low purification vacuum, so they're better than a HEPA vacuum that is specifically made for biohazards, so that one tech is actually holding that nozzle at the saw while the other one is doing the procedure. I haven't used one of the adapters that are sold with these saws, but I hear they clog and they have a lot of problems. This is working great for us. We're using an isolation suite for everybody that we do. We have N95 and appropriate PPE as approved by our EH&S people for our fresh tissue dissections. And then people feel like, our oversight folks feel like once the tissue is well fixed, that droplet and splash protection precautions are probably sufficient. We continue to adapt. We are testing everybody on every case. And this is, again, from the document that I've put together that I'm happy to share, what we think we're going to have long-term to be able to really get to where we were, or to get back to where we want to be. And that's going to be, we need to be safe from SARS-CoV-2, whether that's through widespread immunity or an effective vaccine, whether we have some effective treatment for SARS-CoV-2. And until that's the case, we're going to have the engineering, the administrative, the personal protective controls in place to that we know are protective from aerosols, right? We know that this is infective by aerosols, and that's a major risk. We're already working very hard to make sure we don't have any sticks or anything for HIV and Hep C and stuff like that. And so I feel like while there are unknowns around COVID-19, we do know, as pathologists, our safety folks know how to protect ourselves from the various routes of infection that this virus has to operate under. And so that's why we think that the controls we have in place are sufficient, and we feel safe, and we are up and running to basically be back to where we were, with the exception of some new costs and new testing that we have to do. So I'm going to stop there. I don't need to go through all of this stuff. It's been a whirlwind journey for the last 6 weeks. I've gotten to know a whole lot of new people, and I've come to really appreciate, even more than I already did, our team at the UW ADRC, and of course the NP Core team, including the techs and the faculty that have really stepped up and helped out with this. So I'm going to stop there and turn it back over to Pete, or to Cerise, or somebody.
Are we ready for questions?
I think so. I'm looking at two questions.
Yeah, okay? Go for it, Pete.
Okay, I have
having fun.
One is how fast is your rapid COVID test? And we have a 2-hour TAT test, but the actual resources and have not been very well shared across everywhere, and so we have not had enough of those to give to everybody. We have a 8-hour test that we do Q8 hours at our center that we have substantial enough to do it in. How fast is your fastest test, Dirk?
So our test is currently 2-hour turnaround. That does not include us bringing the test to lab medicine. The time it takes for them to start their run, they start their run every 2 hours. So if we bring it an hour before they start, it's going to be a 3-hour turnaround. There's a lag in actually getting the results back, which is 15 minutes or so. So in reality, even though it's a 2-hour test, it's 3 to 4 hours in our experience. And that's just too long for some of the things that we're doing with rapid autopsy.
Okay,
we really need.
We got other ones. Let's just bang through these ones, and maybe we'll circle back. Is that okay, Dirk? Okay, so that's a good question. Question number 2 comes from Victor Henderson. How do you plan to share fixed tissue? And I think the key thing for that is to flag tissue as being tested for COVID or not. I think that that's going to be a new standard that has to be for every sample. I think going forward, we need to know whether or not we've tested it or not and consider it to be COVID positive if not. Do you agree with that, Dirk?
I do, and we're going to have to figure out what the best way to test not just patients but the brain tissue itself is.
Great. Maggie Flanagan asks, any guidance on how long to fix COVID brains? Dirk, do you have any thoughts on that?
Yeah, so there's data on coronavirus inactivation with formalin that 3 days at room temperature in 10% neutral buffered formalin is sufficient. We're fixing our whole brains or our half brains for 3 weeks in formalin with one change, and then fixing the cassettes for 3 days before we move on.
We're going to probably adapt a month long for that, just for whatever that's worth. Rick Perrin asks, what is the sensitivity of the rapid test and versus what gold standard? We were told, we've had some very different takes on the testing. Even the one that's the 8-hour one is said to be 98% sensitive, but there are definitely false positives. Dirk, I know that you have some anecdotal evidences on that.
Yeah, so thanks, Rick. It's also quoted as 98%. The challenge there is the efficacy of getting the sample onto the swab, and so I think there's a lot of failures with respect to technique of actually collecting the samples. We do have anecdotal evidence of people who have had COVID-19 who've had multiple negative tests, and so that's a huge issue, and why I think we need to assume they're all positive as we build this out, and that's what we're doing here with our isolation suite.
Great. Okay, Victor Henderson clarifies that he's saying unfixed tissue. Yeah, especially unfixed tissue. That's exactly what we especially most need to know, whether or not this person had a negative or positive test. Eddie Lee, hi Eddie, asks if there are any data on post-mortem COVID testing sensitivity compared to ante-mortem results. Also, there seems to be some data that nasopharyngeal swabs can be negative when the lung is positive. We definitely have had some experience with that. People that get fairly advanced disease, the disease seems to migrate south from the head down into the lungs, and then it's more lethal and you more want to know about it. But yes, and so that there is some anecdotal evidence of that. I'm not sure if there's a scientific literature on that yet. Dirk, can you comment on that?
I don't think so. I think just like HIV and other things, I think there's a risk even if you've tested to have a false negative, and we should protect ourselves for those cases.
Great. Tammy Benzinger says, in my clinical practice, we required 3 negative tests, 1 rapid and 2 PCR on separate days before removing COVID isolation. How confident are you in the results of your rapid test? I think it goes to say that we're not that confident yet. Is that?
I agree. And so we're moving forward without having a known test result to do these cases under the protocols that we think are safe, even with COVID positive people.
Charlie DeCarli, Anita Hutner asked if 10% formalin fixation is enough, and I think that it probably is. It's done for more than at least more than a week or so. But Charlie DeCarli asked if we've changed our procurement approach, and the answer is right now, very few people are procuring anything. I think that the really very big question for me is, what about people that come into y'all's clinics and you're taking their blood routinely every day, day? You know, how are we going to make sure that those people are not both infecting them, getting infection to the staff, how they're not infected themselves, and getting their blood into our biobanks with infected material, and also maybe it could be useful to know that they're not going back and infecting people wherever they're going back. Liz Head says, I'm worried that if we continue freezing brains, are you concerned that we, I missed that one. John Trojanowski says, are COVID positive people who are healthy still able to transmit disease? Yes, there's every indication that that is true. Dr. Elliott, could you get me back to Liz Head's question? I wanted to see what she was saying something. I'm sorry, Liz, that thing just got taken off my screen. Not throwing Dr. Elliott under the bus here, but.
Yeah, you are, Pete, but you know.
I'm sorry.
I had it, hold on.
Where is that one?
It's in the answered column. So Liz said, I'm worried that if we continued freezing brains, are you concerned that we'll have destroyed the tissue for later. It would be painful to do that. Great job.
Okay, thanks very much, Liz, for your comment. I think that there are really good reasons to be concerned, and the degree to which those would, if we just put them back in. I mean, the question is, one question I have is, if we just shut down shop right now and we just took back our shop back in 6 months, would it be fairly okay? And the answer is probably no. The answer is we probably need to really change what we're doing now going forward in an intelligent way. The more we can do that together so that people are on the same page, not bound by each other, not guilted into it by each other, not too much red tape, but just helping each other to come together to a reasonable approach that's good for the pledged support that we've given to these patients, that's good for science, that's good for everything. I think that would be better. And I appreciate all of and we're coming to the end of our 30 minutes. I appreciate all of you all listening. Dirk, thank you so much for your priceless experience and insights. And we're really looking forward to hearing from you, and maybe through the steering committee, maybe elsewhere, but hearing from you in your guidance for how we should figure out how to restart, and these questions that people are asking about changing our approaches. I think that a lot of those are going to come through you. So thank you so much in advance and for what you've already done. And thanks to the organizers. We really appreciate y'all having us to come and talk about these important topics.
Thanks a lot, Pete. Thanks a lot, Nina and Cerise and Nac.
Thank you both. Terrific job.